Welcome, everyone. Welcome to the Hyperfine imaging interview and live demo. We're going to wait for 2 more minutes for the participants to join, and we'll begin in 2 minutes. Thank you for waiting. We will begin in 1 minute. Hello, and welcome to the Hyperfine's webinar and live demo. Today, I'm Khan Siddiqui. I'm the Chief Medical Officer of Hyperfine. Thank you for joining us today. And it's a pleasure to have all you folks join and see what we are doing. Hyperfine built the world's first portable MRI scanner that can really move to the patient's bedside. And we started this vision of building a portable scanner about 5 years ago. And the idea really was to really innovate and make imaging more accessible and patient-centric. And as a first requirement for as we thought of our scanner was really, how do you make it portable? And the second attribute really we thought about was, how do you make it safe with no projectile risk, so that the patient's family members or mother of a child can stay with the patient without worrying about all the electronics she's wearing or any kind of metal jewelry she has on. So making it completely safe and easy to use for individuals. And by doing these two things, we've really been able to think about possibilities of MR imaging in locations and scenarios where it was just not possible before. You can think about emergency departments, right? Sometimes just waiting for an MR scanner in an ER can take hours. Average wait time for MR scanner is almost 90 minutes based on published data. You can do serial monitoring. Scanner can be in a patient's room for any acute condition and continuously monitor and image again and again if need be. Making sure the risk of high-risk patient in ICU don't get any issues because of transport-related risks of bringing them down to conventional scanners, especially if the scanners are far away locations. It's almost no-brainer for rural communities where cost of conventional scanners make it prohibitive to even think about putting some kind of facility there. I mean, you can think of our scanner can easily be deployed in rural communities. Same thing where neurological symptoms are in higher frequency, such as senior facilities and nursing care centers, where having a rapid imaging capability available can reduce a lot of anxiety, a lot of transport-related cost and time-related factors that come into care of patients. And now if you go even further, you can imagine, it can scan in an ambulance and really focusing on stroke-based ambulance where the scanner actually goes to where the patient is. And we've already made a decision on how the patient needs to be treated, before the patient even arrives at the emergency department. Sports medicine, we constantly hear stories about concussions and injuries in young athletes, both in professional and in college athletics. Just imagine having a scanner near the field to be able to image immediately. And again, low cost imaging, providing in urgent care centers where a lot of the false positive and stroke mimickers can easily be identified and ruled out before patients transported for acute care. And then with COVID, we saw tremendous demand for dedicated scanners for COVID units where the same scanners traveling around in the COVID units for COVID patients only and not being used for non-COVID patients. So there have been possibilities that just were not thought of before. And our portability and safety of the scanner is what makes it possible to do these things. So we are FDA cleared and available now and start delivering our scanners this month, later this month. So that has been some great news for us. And we've been accelerating production and deployments. I'm sure if you're following us on social media, you've seen a lot of those deployments that are happening. We've had tremendous demand for the scanner so far. So without further ado, I'm just going to introduce our moderator today, Mr. Henry Soch, who's the principal at SG2, a consulting firm. Welcome, Henry. I'll also answer some of the questions as a Chief Medical Officer at Hyperfine, and then Brian Welsh, our Head of Clinical Science, will also do the demonstration of the scanner and answer any questions that you may have. So just to show some interesting ways we're doing this, I'm sitting in Chicago. Brian and team are in Guilford, Connecticut. So I will be actually controlling the scanner from my iPad, from my laptop, doing imaging remotely. So just showing you other possibilities of remote imaging where you can actually have an expert, if you need to do an expert, do the imaging, whereas scanner can be in some other place. So with that, let's see. Yeah, Henry, you want to unmute yourself and we can start the dialogue.
Great, thank you, Khan. And good afternoon, everyone. My name is Henry Soch, and I'm a principal with SG2. And my role within the organization is to look at technology, innovation, and disruption. And I'm really excited about the conversation we're going to have today because it's going to touch on all three of those areas. So we've been following the COVID pandemic and what's been happening in terms of imaging around that. And so it's a pleasure to be here and to be able to talk with the Hyperfine team today. So I thought we'd start with a couple of questions I think that our listeners may want to hear about. Khan, maybe we could start with you. You know, the company was operating in stealth mode for a long time, and now it's finally become public. So tell us a little bit more about Hyperfine, the company, kind of who's behind it, how you got started.
Yeah, so I'm going to share my screen one more time and just talk about that a little bit. So the company was founded almost 6 years ago now with the vision from Jonathan Rothberg, who's our founder, to democratize medical imaging and healthcare by making medical imaging accessible to everyone around the world. Jonathan put together a team of extremely smart scientists and engineers and physicists and advisors in 2015 to see if we can actually enable portability of a scanner. If you've not heard of Jonathan, Jonathan was founder of a bunch of different genetic companies, did the first genome sequencing on a chip in a company called Iron Torrent. And then he was also founder of our sister company called Butterfly Network, the portable ultrasound device that you've seen. So as part of his incubator, we are the second company that has gone out of stealth mode and realizing his initial mission for the company.
That's great, thank you. And you talked about use cases in one of the earlier slides. Can you maybe share with us how you're defining who the target customer is for this and what, you talked a little bit about the market reaction, but maybe share a little bit more about what the reaction has been to this.
Sure, it has been, you know, I'm always surprised, you know, when I talk to other clinicians, how they want to think about using the scanner and some of the ideas that come up that even we've not thought of. And as a radiologist myself, I've not even considered. So it's been pretty fascinating to see this. Our initial focus has been, in our initial year of launch, has been to focus on acute care setting scenarios, especially where we see tremendous opportunities are intensive care units, neurointensive care units, emergency medicine, and pediatrics, where I think there's a lot of demand and a lot of the issues of safety and transportation that come into play, and cost-related factors also come into play. So you can actually provide a much readily available, accessible diagnostic device in those scenarios. That's how we're focusing on. We've had tremendous demand across various sectors, especially globally, from a lot of folks from not just rural sub-Saharan Africa, but also rural United States, North America, and other places also. So we've been pleasantly surprised and actually glad to see the kind of validation that a lot of the people who reach out to us give us.
That's great. That's great. Maybe we could shift gears a little bit, and I'll ask Brian a question next. Brian, at SG2, we've been kind of tracking, as Khan said at the outset, the kind of impact of COVID and the impact on medical imaging. And part of what we've been tracking is this trend towards bringing imaging to the patient instead of bringing the patient to the imaging department. And we expect that to continue even after we exit the pandemic right here. So that does raise some questions, I think, with people who are familiar with traditional MR settings about safety and some other things. Could you maybe give us a little bit of a highlight as to what that means in terms of being portable around the issue of metal implants and maybe heating from RF energy that's involved?
Yes, of course. That's a great question, Henry. Thanks for giving me a chance. The Swoop's ultra-low static magnetic field strength essentially eliminates the risk from metal projectiles. Metal is attracted to the Swoop's magnet, but only at a very close distance of a few inches. And even then, the force is much gentler compared to a high-field MRI scanner. Metal objects certainly do not turn into bullets around the Hyperfine Swoop. And I'll demonstrate that in a few minutes once I can show you right next to the scanner. And as far as heating, the radio frequency wavelength is so much longer at the Swoop's ultra-low field that metal would have to be meters long in order for them to heat up. And therefore, passive metal that might be found in a patient's body, like clips, meshes, screws, pins, etc., those are not at risk for heating. On the other hand, active implants or any implant that contains a circuit that might resonate, that could theoretically respond to the 2.7 megahertz RF energy of the Swoop. And therefore, you need to look very carefully at the labeling for each type of active implant device and examine it to understand if that device is MR safe, MR conditional, or MR compatible, or incompatible, I should say.
That's great. That's great. Thanks for that. So
Sure.
The other side of that coin, Brian, is obviously kind of site concerns. And we know what the issues are in terms of isolating the magnet from outside electromagnetic interference. With a portable magnet, some of those sightings issues about the metal, the copper shielding are not present, which has some benefits, I think, in terms of cost. But tell me about how you protect the magnet from outside electromagnetic interference.
Yeah, certainly it's one of the most amazing things about the Hyperfine Swoop is that you do not need a special room in order to operate and use the scanner and get good image quality. In fact, I believe that Hyperfine's strongest innovation and most valuable pieces of intellectual property are in the area of our interference signal rejection. And the way we do that is with a combination of hardware and software that the Swoop is constantly using to monitor the surrounding environment. And we're able to separate all those sources of signal interference from the MRI signal that we're interested in.
Excellent. Excellent. I think it's probably worth pointing out to the folks who are listening right now that, as Khan said at the outset, if you want to submit questions to the team to answer, just input those in the Q&A box, and as we move along, we'll be answering some of those questions. Maybe Khan, if I come back to you as a radiologist
Sure.
for a minute. We know that there's been sensitivity about this whole issue of imaging outside of the radiology department. What's been the response of the radiology community to this device and to the innovations that you're bringing to the marketplace?
It's been awesome response. I think the way people are thinking about the scanner and we were thinking about it is similar to what a portable X-ray does. It's an extension of the department outside into the enterprise, making radiology more patient-centric, more engaging in providing services as clinicians demand in rest of the community and rest of the healthcare setting. So we think of it as an extension of the radiology department, right? I mean, interpretation still will happen primarily in radiology and images will still go to PACS. Either we provide that PACS or they use their internal PACS for integration. So yeah, it's an extension of our radiology department. I think as a director of MRI in my earlier days, that was some of the wish lists I used to have, like how do I make sure we can provide the service right where the patients are, so don't have to deal with cost issues and wait time issues and other things that we have to deal with today. Yep,
that's great. And Connie had mentioned at the outset, in your use case scenarios, you mentioned COVID. How has COVID impacted Hyperfine in terms of demand for the service as a company?
Yeah, it was interesting that we started getting requests for COVID scanners pretty early on, and we had to accelerate a lot of our timelines on production and deployment around that. North Shore University Hospital, part of Northwell Health Network, was the first one to get our COVID scanner. They had 6 ICUs with 110 patients distributed on them, different floors, intubated, and they were driving our scanner around from floor to floor, imaging a lot of these patients who had neurological symptoms. And just to give you an idea, at the peak of the whole pandemic, they discharged 12,000 COVID positive patients from that hospital. So the volume was pretty tremendous amount of volume. And I think what I've gotten from them is that and the Swoop really made a difference in patient management. They were just inundated with number of patients coming in and requiring imaging.
Yeah, living in Connecticut, I'm familiar with the Northwell example, so we were following what was going on across the border in New York State. So I think at SG2 we have a demand forecast. I think our impact of change forecast, when we look at MRI services and identify which clinical service lines drive those volumes the most, I think we see the kind of traditional neurosciences, orthopedics, pediatrics. Could you outline for us a little bit about what clinical applications are currently cleared by the FDA and which ones you have in development to address those service line demands?
Sure. So our device is cleared for all neuro applications from newborn to adults. That is what our initial submission were. We are working on extremity imaging, and hopefully we'll have timeline coming out soon on when that will be available. But that's some of our focus on doing extremity imaging for orthopedic, podiatry, and other markets.
Yep. And so the other issue I think that obviously comes to the forefront when we talk about this, especially in this environment where hospital margins and reimbursements are under pressure because of the requirement to kind of defer elective procedures right now. How are hospital finances stressed, and how do you fit into this environment? How do you, in a capital constrained environment, how does Hyperfine play in that environment?
I think we innovated earlier on in the pricing model side of things, as we are seeing other industries and even in healthcare move more towards a subscription-based model or pay for service kind of models around that, even capitated value-based models. So we start thinking about how would we innovate in our business model side of things. So we decided, in addition to our capital purchase option, we'll provide very affordable, low-cost subscription-based model, just really subscription fees that you pay. So it ranges between $5,000 to $7,000 a month, and covers everything: the scanner, the software, all updates, unlimited cloud storage, integration with PACS and EHR, and whatever is needed, delivery, unlimited training, all inclusive. So no nickel and diming the system on different sequences and all the stuff. It's everything that is now available, and every feature upgrades that we do to sequences and new sequences come out that become part of that.
That's great. So different purchasing models that are available for the instrument itself. That's great. So I'm sure we want to get to the demo, but before we do that, I'm sure that our listeners would be interested in kind of understanding where your clinical sites are right now, who's been evaluating the system, and maybe what future plans are for the company in terms of your expansion.
Sure, absolutely. So the longest partner has been our Yale University Health System and Yale New Haven Hospital. I think they have scanners now, have been there for more than 2 years. They currently have 3 scanners, one for neuro ICU, one for emergency medicine, and one for dedicated COVID unit. We deployed at UPenn, we deployed at, as I mentioned, North Shore University, Northwell, Good Sam Hospital, Long Island, NYP, MGH in Boston, part of Partners Healthcare, University of Chicago, as well as Nationwide Children's Hospital. And we also have one scanner in Florida Gulf Coast University down in Florida, and we're deploying more on every day. I'm probably missing a bunch of them on there, but we have, yeah, those are our active sites that are been using pretty heavily.
Sure. And do you have plans for global expansion as well outside the United States?
Yes, we are working on the plans currently, actually actively figuring out, what our next expansion idea is going to be, and we will be announcing those later this year on what our plan is going to be. But definitely, I think there's a lot of interest, a lot of demand from global point of view. And as we scale our manufacturing and as we scale our capacity to go to other markets, we'll definitely announce those in the future.
Oh, that's wonderful. Well, I'm sure people have enjoyed the question and answer session, but if I'm like anybody else, I'd like to see the scanner in operation. So why don't we move to the, let's do the demo and get a chance to see this.
Awesome. So while Brian, you get your mask on and start going, maybe Henry, we can answer some of the questions that are coming up.
Great.
And I can start tackling some of them. So I think the first question was, what's the field strength of the scanner? It's a 64 millitesla scanner. I think that was a pretty straightforward question. Other question was, what type of license would be required to operate the scanner? I think it'll depend on what the local laws require. We've designed the scanner to be very easy to operate. So, anybody can use it, and I'll show you the user interface and how easy it is to use it once we plug in the scanner. So I'll let Brian take over. Brian's going to start the scanner and drive over, and let me switch to
the first type of MRI scanner where you actually get a keychain with a key to drive it, because it moves.
It looks like these corridors are even narrower than what you see in hospitals, right?
Yep. So easy to drive. Brian has a joystick on the left side of his hand that is controlling it, bringing it to the patient. He's closing the 5 Gauss guard. That's the extension of the 5 Gauss line. So anything beyond that is totally safe. He's positioning it next to the patient's bedside. So you saw, very easy to drive around, very easy to bring it next to the patient, plug it into the wall, and just go.
This plugs into just a standard power.
Uh-oh.
Just had to mute our audio.
You should be good now.
I think we're still muted in the room.
Yeah, we're still muted in the room.
You can unmute over there. Okay, I think we're okay now.
Yep.
So this is just a normal power cord and normal power outlet, 110 volt, 15 amp, that you'll find in any patient's room or any other part of the hospital. And I'm going to turn to scan mode and power it up. And you saw that I lowered this bridge to close the gap between the bed and the magnet, and Sam is assisting me with the pad. And we have a volunteer subject with us today. And we're going to show you how they do it just the same way in the neuro ICU at Yale and other places. The patients are in their beds already on top of sheets. And so it's very easy. The team of nurses will just lift the patient by the sheets and slide them in. And you can get a good visual look. If you're not all the way in, you can shift them in just a little more. On Sam's side, the little bit of RF screening we do have opens up so she can access the patient's head and help guide them in. You might be able to hear a few clicks and pops. That's the auto test phases of the scanner running. And that's it. I'm going to go ahead and hook our volunteer up to a pulse oximeter just from a standard patient monitor. And Khan is able to control the scanner from Chicago across the web page interface. Oh, I promised to show you the strength of the field. So I'm going to take this keychain here and show you that it'll just barely grab it. And it doesn't put John at risk at all. It's very gentle. It's not like a bullet or a projectile effect really at all. We've had patients with oxygen tanks wheeling right past it as we moved it through the neuro ICU at Yale. Oh, yeah. One critical thing for Khan to take control, we need the Ethernet. We can connect to Wi-Fi as well at the hospitals, 2.4 gigahertz or 5 gigahertz. So now we're on the network. Khan should be able to reach the scanner. I'm going to go ahead and turn this monitor on behind us just to prove that we can have these electronics surrounding the scanner without any concerns at all of interference from them.
Okay.
Normally, if Khan were not operating the scanner, we would operate it locally with this tablet computer, an iPad tablet, which is showing some phantom images from earlier when we were preparing for the webinar. So as soon as Khan starts the exam, these images will start updating with images of John's brain.
Awesome. So I'm in Brian, if you can see my screen. So I'm just entering some patient information to get started. Typically, this will come directly from the modality work list if the order is already placed by the clinician. So we do integration with that, and that would provide all the information. But if you need to manually enter it, you could do that too. And then, you know, it's very easy to use to start with. You know, just select what indication it is. You know, if you're doing for a bleed, doing a general exam for headache, for stroke related stuff, just select that and it'll show all the sequences and start scanning. If you want to select a particular sequence yourself, you can do that too. So I'll add a pre-calibration scan here. Let me get rid of the localizer, and then we'll do a fast T2. Let's do that as part of that stuff, and then hit play. So typical protocols can be done, and if you want to do a specific protocol, that'll start too. So the audio is on in the room.
I'm going to hold it close to the scanner so that
yep.
The acoustic noise is much quieter than a conventional high field scanner. We didn't put any ear protection into John's ears, no earplugs. You're going to hear some clicks and pops and the shim mapping sequence running in just a moment.
So it's doing the pre-scan calibration right now to see what is, you know, just measure the environmental noise and cancel that out as actively, and it'll continuously do that. We'll start seeing images in it. I'm just going to walk through some of the tabs here. You can also do 3D visualization of these images as they're coming up. There's total exam time and how much it's going to take to finish the exam.
That's about as loud as it gets, what you just heard.
Great. A few more seconds left, and then T2 will stand. So it's about a 5-minute, 42-second scan, and then another minute and a half or so for the image reconstruction that will happen. But the way we do progressive rendering, as soon as 10% of data is collected, we start showing images, and I'll show how that happens in a bit as the T2 scan starts. And then Brian and I both can see the same user interface on the scanner. He can be doing something, and while I can be supervising it from a remote place or modifying the sequence as it's needed. Okay. So T2 scan has started. I'll go into the scan window and we'll start seeing images show up as soon as it gets into 10% of data is collected. So we do volumetric acquisition, so the entire head is imaged at the same time. And as more and more data is collected, the image resolution and image quality starts getting better and better. And Brian is putting the microphone right next to the scanner. That's the loudest, that's the scan you, I think the pre-calibration scan is probably the loudest one, and that's the noise you're getting. So none of the high decibel noise that you see in conventional scanner. So even from that point of view, it's really quiet and easy to deploy in patients' rooms. Okay. Henry, we want to capture some more questions while we are waiting for the scan to go.
Should get our first image update any second now.
Yep.
Con, there was one question I thought
Sure.
around reimbursement changes. Do you foresee any reimbursement changes given the relative low cost of Hyperfine versus conventional? I don't know if you want to tackle that or.
Sure, I can tackle that, but just wanted to stress quickly, the images already start to show up. So if there's any big pathology that was going on, you would have known within 2 minutes of positioning the scanner or 3 minutes of positioning the scanner and starting the scan. So, and you'll see the scan quality keep improving. So I think personally, we think the from a reimbursement point of view, all the low field modifiers will apply to any imaging that happens. The things we are focusing on the inpatient side of things, probably most will be covered under DRG reimbursement. And if people want to use another scenarios that are not covered under DRG, then it'll probably require low field modifiers or limited modifiers to those reimbursement codes. I think I would recommend folks to talk to their billing departments and local peer relationships to see how they want it to be billed and how will the payer reimburse for it. But I think the low field scanners are not uncommon. I mean, that's how MRI imaging started at 0.05 Tesla and 0.64 Tesla in the late 80s and early 90s. Cool. So a couple of questions that are coming from the audiences. One question is about, are you able to do time of flight imaging and DWI imaging? Brian, you want to talk about that?
Sure, I'll start with DWI. We have that as part of our FDA-cleared system. We do B values of 800 seconds per millimeter squared, and we're constantly working to increase that. We offer the B equal 0 image, so we can make an apparent diffusion coefficient map as well. So that is available now on the system that you can order. Time of flight, angiography or other forms of angiography are works in progress. Our engineers are working on sequences right now. There are some challenges there because T1s are shorter at low fields, so the background suppression of the other tissue compared to the influent blood is a little bit more of a challenge. But we do believe that angiography is possible, and especially in combination with possibly some contrast agents that we're exploring.
So another question from the audience is how other emergency departments may be using the unit for acute stroke care. Brian, you want to talk about our ER experience?
Sure. We are deployed at a few ERs, one at New York Presbyterian Brooklyn Methodist, one at Good Samaritan, and one at Yale now. I'll give you the example of a Good Samaritan. They're one of the hospitals that have an ED observation unit where people with stroke-like symptoms that may have started to resolve will be placed into that observation unit. We may be there for 12, 16 hours without being admitted into the hospital. And the majority of them will undergo conventional MRI. So Dr. Chris Rayo there at Good Samaritan is able to use the Hyperfine scanner to scan them while they're waiting. He can just go bay to bay and be looking for those cases that might be severe enough or urgent enough to prioritize those people to get either more imaging or to go directly to an interventional suite. As far as strokes that are not acute, the ones that are known to be there, we've seen many of those in the neurointensive care unit. Many different types of hemorrhages, interparenchymal, interventricular, subdural, basal ganglia bleeds. And then we've also seen many different ischemic strokes of all shapes and sizes and kinds, MCA occlusions and smaller ones. That's what we saw on some of the COVID patients at North Shore University and at Yale.
Thank you, Brian. So scan's more than halfway done. As you can see, the image quality keeps getting better and better as more data is collected. And as I mentioned earlier, we sample every 10% of data, so you'll see image quality improving as data is coming in. 10 seconds left to almost done.
And I'll point out that if this were a longer exam with more sequences that were following this first T2-weighted fast-spin echo, there would only be a very brief pause of a few seconds before the next scan would immediately begin. So there'd be very little dead time between sequences, while the T2-weighted fast-spin echo is going through a final stage of reconstruction, which takes about another 90 seconds. So as you're scanning a patient, it's very efficient. It gets the scans done one after another. And as soon as the scanning part is complete, you can take the patient out. And then it's just about another moment or two, a minute maybe, before the final sequence is reconstructed and the images are ready to push to the Hyperfine cloud packs or push to the local hospital packs.
All right, so that's almost done. Henry, you want to tackle any more questions? Henry, you may be on mute. Sorry.
No, I'm just looking at the list here.
Sure.
I think we talked about slice thickness. We talked about that. We talked about functional MRI and diffusion tensor imaging. Any other scan sequences that are planned for future development?
Ryan, you want to talk about future sequence development?
Sure, we are all, one of them came up already, MR Angiography. We are searching also for options for perfusion imaging. That's something we are pursuing. There was a mention of functional imaging. That is a bit of a challenge at our field strength. So bold contrast, the blood oxygenation level dependent contrast is not very strong below 100 millitesla. So that's something we may not have within our reach. We're very excited about the use of contrast agents starting at sites now that we're moving beyond IRB covered research. So agents that are gadolinium based, dynamic contrast enhanced, also ferromoxetol, ferriheme, the superparamagnetic ion oxide agents, we're very interested in those.
Yeah, and we're also working on deep learning based reconstructions to enhance image quality even further and reduce noise of the scanners even further than it is. But scan is complete. You can see the quality of the images now. I can go into our 3D display and do more stuff if we need to. If we go to flat. Yep. So yeah, we can go through different slices and scan through this entire data set around that. So I think I'm going to stop sharing my screen and let's get back on a few more questions that people may have.
Con, we did get one question about system availability. You had talked earlier about shipments can start in September. Kind of what's the availability? When are units widely available? And is this US only for now, or are you shipping outside the US?
So systems are available widely now. We are deploying almost on a weekly basis as they're coming off, and we are scaling our production capacity even more. From a commercial point of view, we are deploying in the US currently. And as I mentioned earlier, that we have global expansion plans. We'll start announcing later this year and early next year and where we're going to be going next. But we are deploying some research-based scanners internationally currently also. So those are some of the things we are doing. Anything you want to add, Brian, to that?
No, I think you covered it very well.
Okay, cool. I think the price question, I just want to clarify one more time. So there are two pricing options. One is subscription only option that includes everything: delivery, training, unlimited software updates, new sequences as they come out, unlimited cloud storage, PACS viewing that we provide, or integration to local PACS and EMR as needed. And it starts at around $5,000 a month and goes up to around $7,000 a month, all inclusive. If somebody's interested in buying a scanner, it's a $50,000 hardware purchase, and then about 4,500. Again, there's a scale on a subscription, software subscription that goes with it on a monthly basis. So again, just want to stress that the scanner is significantly cheaper than the maintenance cost for conventional scanners. It's relatively inexpensive.
We did get a question, Con, about service and maintenance requirements. Could you comment on that?
Ryan, you want to take that one?
Sure, that's part of the beauty of the Hyperfine as a service approach that we're taking. All of the maintenance, the routine and the break fix maintenance are all included. So different from conventional high field MRI where that would be a separate plan, negotiated separately. That's all bundled together and included. So you're getting the maintenance, all of the future software upgrades and updates, automatically you get those, and the unlimited access to the cloud storage and viewing and all the tools that we're building for the cloud that are AI and deep learning based. So it's all together, maintenance, software, and cloud and tools.
That's great. So we did get a question about, Brian, maybe for further elaboration around future kind of planned clinical indications for the scanner. You commented on some of them. Maybe if you could just reinforce that for the audience, they'd love to hear that.
Sure. Well, I'll start with that. So our FDA-approved indication is general imaging of the head. And that can capture a whole lot of different things. What we've observed so far are mostly intracranial pathologies, the hemorrhages, ischemic strokes, midline shift, mass effects, tumors pre and post-op, hematomas, hydrocephalus, enlargements of the ventricles. So that's all we've observed so far. And we think that's going to just continue to expand as we get this in the hands of clinicians that are in EDs and in our ICUs. If I look ahead on our roadmap, if we go beyond the head to the neck and C-spine, we're looking at ligamentous injuries there, musculoskeletal applications, again, ligamentous injuries, also diabetic foot disease, diabetic pedal disease in the form of osteomyelitis and ulcers. We've had suggestions to look at scaphoid fractures in the wrist. So there's a lot on the horizon for us that we're excited to try. But for now, our FDA clearance is for the brain or the head.
Cool.
Conrad volunteer has exited the scanner. He's doing just fine. I think he had a relaxing nap in the scanner.
Henry, you had another question?
Yeah, just I think from your perspective as a radiologist, I think we got one question about since it's a little bit difficult to evaluate image quality on a webinar, was the resolution sufficient to quantitate cortical thickness?
I think so, absolutely, right? So I think you, folks can see some of the sample scans we have on our website also. We'll be updating more and more in the next few weeks, so you can evaluate the quality yourself. Maybe I can share my screen again and zoom into the image. Just give me a second. Brian always reminds me I can do some of these stuff just by showing the scan. So, I mean, this is T2 weighted scan. You would normally do a T1 weighted scan to look at cortical thickness related scenarios, but you know, it's pretty good image quality to be able to see a lot of different things.
We do have collaborators that have used the T1 weighted scans from the Hyperfine Swoop, passing it through segmentation algorithms to segment white and gray matter, deep gray matter, and especially if you're willing to spend a little bit more acquisition time to up your signal to noise and up your resolution, you can get nice segmentations of those tissue groups.
So Brian, I skipped a question earlier that I think I'd like to ask you now, and that is, how did you come up with the name Swoop for the system? It's kind of a unique brand name in the marketplace.
And that was one of our goals. We wanted it to be a unique and memorable name, but we also wanted the name to capture the speed and the simplicity of the system. And we were also really wanting a name that could be used as a verb. We foresee a day when medical doctors are saying, let's swoop this patient right away. And so we wanted to come in with a name that would definitely catch people's attention and also capture some of the properties that we think are the most desirable and differentiate our scanner from other things out there, that it's accessible, fast, simple.
I think there was a question about what iPad would we use. I mean, we provide that as an iPad Pro as part of the device, so that's also included in that subscription fees.
The iPad is included, but as Khan is doing right now, any web-enabled device that can has the credentials to log into the scanner, you have to have those credentials, can pull up the web page and operate the scanner. So, but we provide the iPad tablet as part of the delivery.
Any other questions we need to take? Okay. Henry, you want to close the call? Maybe any remaining questions that come in, we will be providing those to attendees shortly.
No, I was just going to say thank you for the demo. It's really impressive. I was especially impressed with the question about the service costs and stuff like that. So that all-inclusive thing is tremendously interesting. Connie, do you have a couple of closing comments that you wanted to make, and then we can thank our attendees for joining us this afternoon and encourage them to follow up with you if they have any additional questions?
Sure, absolutely. So no, it's been tremendous bringing this scanner to market and really seeing the difference we can make in patients' lives. And I hope we've answered a lot of the questions live, and we will provide attendees with answers to remaining questions that we have. If you're interested in getting a scanner, you can approach us through our website or send us an email for inquiries. Also, the contact information is all on our website. There's also a pre-order form if you wanted to go and place an order for us to reach out to you to have further discussion around this. So, but it's been exciting to have. And Henry, thank you for moderating the session and bringing up some interesting questions.
Thanks for inviting me. It was great fun. Thank you so much, Con. Congratulations on the great work.
Thank you. Thank you, everybody. Have a good day.
Thanks.